of the acromion process. However, there is preserved alignment of the acromioclavicular joint and the right glenohumeral joint. No fracture or soft tissue swelling, and the lungs on the field of view is unremarkable. Maybe there is obliteration of the right costophrenic angle. Like either I would like to see other views of the right shoulder if there are any.
No further views available.
Okay. So deformity of the acromion joint with a little bit of sclerosis. Yeah, my top differential would be sclerotic metastasis.
And why do you say that?
Like no definite lesion that I can see, just sclerosis and a little bit of deformity. And no, and like no fracture. So
right.
That's why I suggest, yeah.
Look at the clavicle. What's happening to the clavicle?
A little, okay, it's like I would like to compare with the other side, but it looks thickened.
What do you think is happening here, where I'm pointing out? Can you see my mouse? This is the lateral end of the clavicle. What do you think is happening here?
It is pointed. The lateral end is pointed. So it is like, but I can't see regularity of the distal end of the clavicle.
Right. What has happened here, where I'm pointing out?
Cortical breach and angulation.
So is it a breach or a?
It's more like below the area that we have pointed towards, like it's angulation and a little bit of break or breach below it.
If you are worried about a break here, let me tell you that there is no break here. So that is just projectional. You know, there is a lucency which is going beyond. So don't worry about a break.
So angulation of at the level of the right humeral neck.
Do you think the head of the humerus is normally located?
It's projecting over the glenoid cavity.
And superiorly?
Yeah, but it's still well aligned with the glenoid.
Right. So, in relation to the AC joint, what do you think?
Yeah, it is like subluxated superiorly, and there is maybe the coracoclavicular distance is reduced as well.
So this is a 81-year-old, you know, cannot move this shoulder. And what do you think is happening?
Deformity, increased density of the shoulder, no signs of infection like soft tissue swelling or is it Milwaukee shoulder deformity, disorganized shoulder joint?
Okay, thank you. Let me go through some teaching points, and then we will come back to this case. Now, so this is case one, and this case one is rheumatoid arthritis. And what is the inference with it? That there is complete tear of supraspinatus with superior migration of head. Oh, there is a typo here. Apology for that. Of course, this is head of humerus and resorption of distal clavicle. So here comes a differential diagnosis from Chapman, which is erosion or absence of the outer end of clavicle. Now, erosions can be, of course, there are common causes, less common causes. Rheumatoid arthritis, you did well. You did ask for comparison. Of course, that even without comparison, one can reach the same diagnosis. And for your exam, the most important one is rheumatoid arthritis. And then with that, uh, I am, somebody is saying in the chat that the slide is not seen. Is it candidate one? You can see my slide.
I can see the slide, not the image, but the differential from the Chapman.
Yeah, of course, of course. So, and hyperparathyroidism is extremely important. So always remember these two, particularly important. Now, with that, if you see here, what happens in rheumatoid arthritis. So this is a case which is from ACR, and similar case actually. This is a 61-year-old. If you see, look at the clavicle, it is not visible and means it is missing, it is eroded. With that, what has happened is that there is a complete tear of the supraspinatus. So, just to give you the perspective, this is an MR of a totally different patient. But here the learning point is that supraspinatus. So the supraspinatus sits here. And in this case, there is a what we call a massive tear of supraspinatus, and the musculotendinous junction is retracted medially. Now, what happens is that when this happens, there is superior migration. Don't use the word subluxation, superior migration of the humerus in relation to the glenoid, which is actually, you can infer it here also. So in this case, there is a chronic, similar finding, chronic. The head of the humerus has gone up. And of course, now this thing here is just a mechanical defect. So what happens is that the inferior margin of the glenoid, it is hitting this, the junction of head and surgical neck, and this is a mechanical type of defect there. It is a depression in the bone. So similarly, in our case, if so, here just to highlight another example of bilateral uh, erosions. So don't think that erosions will have an always an irregular outline. You will simply see that as if the bone is tapered, as I showed you, and at times it will be simply missing. This is a case of hyperparathyroidism in which you can see that the lateral end of the clavicle is missing. So, going back to our case, which was this one, we can see, you know, so you can infer that this is the joint distance. So all of this bone is eroded. There is superior migration, and this is that defect which I pointed out. You are absolutely justified in asking for better views, but I wanted, at times the patient cannot even tolerate a better view, by the way. So, whatever I wanted to ask, we could see on this image. So this was your first case. Well done.
Yeah, thank you.
Okay. So, madam, this is a case 44-year-old female came to an acute abdomen.
Okay. Shall I ask for control or?
Yes, please. Ask for the mouse.
Let me check.
So
Yeah.
the mouse is with
Awesome.
you.
Okay.
Just one second, let me change the density again and change the size for you. Now you scroll, or this thing here. If you want, you can
Yeah.
sort of scroll through
Okay.
that. Over to you.
Yeah. Okay, so I'm presented by axial CT scan of a 44-year-old um, female patient presented by acute abdominal pain. Just take a moment to have a look. Okay, the abnormality is just in the right lower abdomen. There is a peripheral enhanced lesion with central hypodensity surrounded by fat stranding. Um, just trying to see, just superior to the urinary bladder, and um, not continuous with the bowel. So this is an area of this appearance is likely to be inflammatory and giving the enhancing peripheral enhancing wall. So this is like to be abscess, abdominal wall abscess. Sorry, intra-abdominal abscess. No other abnormality that I can see in the abdomen. I would like to change the window to lung window to see if there is intra-abdominal gas, no free fluid. There is IUD in like satisfactory position. I'm checking the adnexia, so no adnexial lesion. I'm trying to see the cause of this abscess, but I can't see any reason for having intraperitoneal abscess. Gallbladder is normal.
Would you like to see any other sequence?
Yeah, lung window, please.
No, lung window is not going to help you. What I meant was any other plane.
Yeah, coronal, please.
Corona. If you can leave the mouse, please.
Yeah.
Leave the mouse.
Yeah, I left.
So here you are, corona.
Yeah, thank you. So
let me undo the window for you. Just one second. Just
yeah.
one second.
Yeah.
Over to you.
Okay, so coronal reformat. Same scan. Okay, so again, the redemonstration of the same lesion superior to the urinary bladder doesn't seem to be continuous with the small or large bowel. But given this position, like this location, I suspect that might be coming from the appendix, appendicular mucocele, In my routine practice, I would change the window to see if there is perforation. However, from this view, I
Just one
can't see
second, madam.
any
Madam,
gas
excuse
locule.
me,
Yeah,
excuse me. I'll give you another sequence. Over to you. Sagittal for you.
yeah, thank you. Uh, okay, from the sagittal, same location. It's away from the adnexia, and there is fat plane between it and then the urinary bladder. Um, from this view, I'm not sure if it is continuous with the bowel or not. Um,
Okay, can you conclude the case?
yeah,
What is
my conclusion is a patient, 44-year-old lady presented by acute abdomen. This is likely to be there is well-defined in peripherally enhanced thick wall lesion with extensive inflammatory markers, inflammatory stranding, fat stranding around it. Um, given the location in the right iliac fossa, this is likely to be appendicocele. However, I cannot see any appendiculus, and this is for surgical review.
okay? Thank you. Thank you. We'll come back to the case.
Okay, thank you.
So this case is an infected vesico-urachal diverticulum. And anatomy is the key here. Anatomy is the key, the location. So let's go back to a bit of embryology and what kind of presentations can happen. In a fetus, there is allantois, and after birth, what happens is that it just obliterates, and there is a fibrous, urachus. There is a connection.
Yeah.
This is a fibrous structure without any fluid or anything, which is normal. It extends from the fundus of the anteriorly. Key thing is it will be just deep to the anterior abdominal wall. It will arise from the fundus and will go all the way till the umbilicus. Now, with this, there can be various kinds of anatomic or embryological variants, which can present in later life with acute symptoms. And so the first thing is this one, where there is a diverticulum. You can see this is known as vesico-urethral diverticulum. And our case was this with infection. But anatomy tells you how you are going to call it. So there is a bit of communication between this and the urinary bladder. Sometimes what happens is that the obliteration continues below and superior, and there is a locule of fluid there. We call it a urachal cyst. Sometimes it will be in continuity, a sinus tract to the umbilicus, and we call it umbilico-urachal sinus. And sometimes it is like this. It is patent. So usually presents in infancy, early infancy, where it is completely patent and the connection is with the urinary bladder. Now, this so this is from your Chapman 9.39 urachal lesions. As I have just told you, the embryology of whatever it is it resides in the extraperitoneal space deep to the rectus abdominis in the midline. Now, so the same things are written here, which I have just told you, and these with that, what can happen? It can present with infection, and there are few tumors also, which are sort of associated with it. So read this one 9.39. This is
Yeah.
case from my collection where the key thing is this sagittal. So you should have asked for the sagittal because it was just superior to the bladder. It was in the midline. Midline just superior to the bladder. Now here, one can have a debate: is it a urachal cyst or a vesicourethral diverticulum? You can see this very well defined, but you can argue that there is a bit of connection here, but the connection is not very well seen. In any case, you can have both kinds of opinions, but I think looking at it very closely, we call it a urachal cyst, this one, in our report. But we might not have been right. Having said that, this is just to tell you, and at times this cyst might be sitting up here and when you protocol these scans, you please remember the anatomy. So you will ask your radiographers to cover, sometimes what happens is that on a CT everything is not very well visible, and then you will ask for an MR to highlight the whole tract from here to here. So this anatomy is critical for you to know and remember. Now let's go back to your case. So your case was this one, and you did well, where you described, and the way you described, I like that, and you did rule out, you did mention adinexa, etc. But the key thing was anatomy. Where is it? So you got a bit confused as if it is appendix because the cecum was also there. You asked for coronal, which was fine because your mind was going towards appendix. And you thought that, but I think sagittal, because it is, now this is urinary bladder. If you see here, uh, it is going, and here you are. So you were justified in thinking about an appendix, but once that was ruled out, sagittal you should have asked. And on this sagittal, if you look carefully, this is very clear. Look at this wall of the urinary bladder, and this is all thickened. There is fat stranding here, and then there is abscess. It is not related to anything. So your anatomy and your knowledge of the normal, embryology, that will make the diagnosis. Thank you.
Thank you.
Your next case. Your next
Mhm.
case is
Okay.
32-year-old male. Presented to ANE with uh, headache, 32-year-old.
Okay. Um, I have the control.
You can ask if you haven't got.
Okay. Yeah.
Now you have got the control.
Okay. So I'm presented by axial CT scan without contrast of a 22-year-old gentleman. Just take a moment to check. This is brain window. Okay. So the abnormality that I can see here is in the right um, occipital, sorry, it is right posterior parietal lobe. There is hyperdense lesion in the right posterior parietal and occipital lobe surrounded by hypodensity. Um, no mass effect, so no midline shift, I mean, and no hydrocephalus, no other similar lesions in the infratentorium or on the left cerebral hemisphere.
So what is this?
Um, this is intracerebral hemorrhage. Sorry, I missed the presentation he presented by.
Headache, 32-year-old headache. So when you say that this is hemorrhage, what can be the cause?
The cause is rupture aneurysm, intracerebral aneurysm. I think there is
Aneurysm.
no history of.
Just 1 second. Why did you say aneurysm? You know, this is intraparenchymal hemorrhage. Look at the anatomy. Which vessel will bleed there?
Yeah, it's likely to be subarachnoid hemorrhage, not intracerebral. Yeah.
So what can be the cause? 32-year-old young male.
Young male hemorrhage. No, like maybe traumatic, but there is no history of trauma. Hemorrhagic metastasis from non-primary.
What will you do next? What will we do next?
Next, I'll do a CT scan with contrast.
Okay, so what we did was that we did an MR. Just hold on, please. Just hold on.
Okay.
Over to you.
Okay, so this is axial T2 weighted image, MRI brain of the same patient. So the right occipital loop, in the right occipital loop, there is well-defined, mainly hyper-intense lesion surrounded by hypointensity and edema, vasogenic edema. I would like to check this lesion in the SWI. This is likely to be hemorrhagic lesion from this heterogeneous signal intensity.
Just 1 second, please. 1 second. 1 second. Leave the mouse.
Yeah. Okay, so SWI, there is blooming artifacts in the lesion suggestive of vascular origin. So this is likely to be cavernoma, given the patient's age and presentation. I would like to check the whole series to check if there is any other cavernomas.
Why do you say it is a cavernoma?
Heterogeneous high signal intensity in T2 weighted image with blooming in the SWI. The second differential could be hemorrhage as well. But as it is more like it's intra-axial, so I put cavernoma or vascular malformation in first differential. Yeah.
Just 1 second.
Sorry.
1 second.
Yeah.
Over to you.
Okay.
Just give me, just let me quickly show you. This is the T1. Because of time factor, I am showing you myself. This the T1. Just see. What do you think is happening on T1?
T1 bright signal intensity. So it is blood.
Now over to T2 coronal.
Okay, T2 coronal is where it is.
Now you can take the mouse here.
Yeah, it is heterogeneous, again, hyper intense lesion with rim of hypointensity. So this is acute on top of chronic bleed.
So what is your final conclusion? Give me your diagnosis.
So vascular malformation, likely cavernoma with repeated hemorrhage. Or, I mean, because there is separate. It's homogeneous hyperintense in T1 and heterogeneous in T2. So suggestive of different age of blood.
Okay, I'll take over. Thank you.
Okay.
So your diagnosis was correct, but you know your concepts. So let me tell you a few things which will, your even if your diagnosis is correct, there were a few mistakes which you are doing, which I'll tell you. Now, this is a case of cavernoma with hemorrhage. Basically, the key point here is that this cavernoma has blood. Cavernomas bleed rarely. The incidence of a cavernoma bleeding is about 1%. And or there is cavernomas can be familial also. And in those patients, there are more chances of bleed. So the key point was that there was a bleed. Now comes what is the cause of the bleed. So let's revise everything and then we will come back to the case. The vascular malformations, this is from your sixth Chapman, because I think in the seventh, this particular differential is not given. Vascular malformations are malformations with arteriovenous shunts and malformations without AV shunts. Cavernous angioma or a cavernoma is without a shunt. And then there is another one which is known as developmental venous anomaly. Before we used to call it, now we call it a DVA. And before we used to call it a venous malformation. Now, basically, cavernomas or cavernous malformation has got quite a unique behavior, and they can increase in size, they can decrease in size, and new cavernomas can be produced. So don't be surprised. So they have got a peculiar behavior. Size will tell you the radiological features. If they are small, then you might just see them on a SWI sequence or a T2 star sequence. When they are large like this, they give you particular peculiar popcorn appearance. So in popcorn appearance, what happens is that there are multiple locules. These locules are blood containing. So some of them will be high signal on T1 and some, slightly different. And key thing is hemosiderin rim. This is the hemosiderin rim, which will be low signal. Now, cavernomas, you do not need contrast to diagnose a cavernoma. It can be diagnosed on usual sequences. But there is a role of asking for contrast, because this can be, I did not ask you, but this can be a question, what will you do? Or you can ask once you reach the diagnosis, you can ask that I will like to do a contrast enhanced MR. But in the same sentence, tell the examiner why. You want to pick up an associated DVA. Literature tells us that between 20 to 35% of cavernomas are associated with venous malformations. And venous malformations, usually you pick up with contrast. So remember this, you are not going to diagnose the cavernoma, but you are going to pick up the associated DVA. Now, this is an example of another cavernoma, which was sitting at the genu of the corpus callosum. And this is that popcorn appearance. So you can see this hemosiderin rim, and you can see these locules, which have got various, aged hemorrhagic foci. Now, this is a cavernoma. These are cavernomas which are very, very small. And please remember, in another clinical context, in another age group, cerebral amyloid angiopathy, for example, will give you similar kinds of blooming artifact. And there is a huge differential for this. Now, uh, this is SWI sequence. This is T2 star. Whatever you people are doing in your departments, it's fine. But this is an example of cerebral amyloid angiopathy, in which there are innumerable microhemorrhages. Similarly, I have seen cavernomas, and they are in my teaching files, where a young patient will have innumerable number of cavernomas. So numbers, will not change. Microhemorrhages on MR is a very important differential diagnosis, and please, cavernoma versus cerebral amyloid angiopathy versus hypertensive vasculopathy. These two, the concepts should be very clear to your mind. And of course, clinical correlation is important, but you should also understand that in hypertensive encephalopathy, vasculopathy, or whatever you want to say, basal ganglia, thalami, etc., are more involved. In cerebral amyloid angiopathy, it spares them, and it is more peripheral, cortical, subcortical. But in another age group or asymptomatic patient, cavernomas have to be kept in mind. It is including familial syndromes. Acute trauma, for example, shearing injuries, always remember that. Diffuse axonal injury. Now, so cavernomas can present in various ways. About 50% of them are not picked up on CT scan. So this exam is also about the examiners like to show you slightly atypical presentation of a common condition. And this is an example of a cavernoma which is seen in the medulla here. So it is a bit of hemorrhage. And please remember, regarding enhancement, usually cavernomas do not enhance, but some of them do. We call it a venous flush. So that doesn't change the diagnosis. So this cavernoma, if you can see, it will be an observation type of a film. Once you pick it up, then you will ask for further imaging, as in MR. And on MR, you can see a T2 star where it shows blooming. You can see a bit of popcorn, actually, particularly here on T2. So this was another cavernoma at the junction of medulla with cerebellum, actually sitting in the medulla. Now, though I have not shown you uh, on the case which I showed you, associated DVA, but let's revise it. What is a DVA? DVA is developmental venous anomaly. Previously, it was called venous malformation. In DVA, key point to remember is that there will be cortical, white matter veins. These white matter veins uh, will be a bunch of veins which will drain into a master big vein. This big vein will go to the cortex. So it will drain ultimately into a cortical vein or the sinus. On the other hand, this big vein can also drain into subependymal vein going into the ventricle. Key point to remember. The main vein will be passing through the white matter. Either it will go to the cortex or it will be in communication with the ventricle. This sign is known as caput medusae sign from Greek mythology. Look at this, which is small snakes. So small snakes are there, and they then drain into a big snake. I call it the anaconda sign. So this is the big anaconda. So 15 to 20% coexisting cavernous malformation. So interesting. If in your exam you get a venous malformation, I'm going to show you a few examples. Then you must ask for a SWI sequence of T2 star. Why? Because about 15 to 20% of them are associated with cavernomas. Vice versa, the presentation is vice versa. So, you get brownie points by giving this knowledge to the examiner. Now, this is a good case for the eye see what the mind knows. This is a contrast enhanced CT scan, and you can see this anaconda sitting here. You can see straight line, and if you look carefully, these two are the caput medusae, and you can infer that it was communicating with, just subependymal, but here it is going out of the cortex. So this is a venous malformation. And this is the same case. Just to give you the anatomy, this is a angiogram, conventional angiogram. Of course, in this era, nobody will do a conventional angiogram for these things, but it gives you a very good view. This is the arterial phase, and this is the venous phase. You can see this caput medusae, and you can see it is draining out. Now, this is a 12-year-old. Another case which I'm showing you from my collection, which is uh, this, cavernoma showing blooming artifact. On this T1, a bit of high signal is there. On T2, maybe a bit of popcorn type of and some hemosiderin. We give contrast, and one can see maybe a bit of blush there. But the but is, you see something else enhancing here. So this is that anaconda. If you see here, this is well seen here. So there is a bit of venous blush, and you can see this artery which is going out to the cortex. So in this particular case, what happened was, I'll show you what happened. When I asked you a leading question that what will be the cause in a young patient, so sinus thrombosis should have been, is, or cortical vein thrombosis is one of the differential. So in this particular case, actually that was called. And why was it called? Because of anatomy. So one key point, I'm slightly teaching you something else. Not in this case, but the way this case was tackled. Uh, not by you, by us. So the teaching point here is hypoplastic transverse sinus. And on MRI, at times you will get a lot of confusion because one transverse sinus is hypoplastic as compared to the other. And then you are, is it congenital? Is it venous sinus thrombosis? Uh, and that is why CT venogram is a very good study, better than MRV. These days we do MRVs, most of the neuro centers they do with contrast, but in our hospital we are still doing without contrast. CT venogram is better than this MRV. And another thing on a CT which you can see very well is the anatomy of the jugular foramen. So whenever you are suspicious of this kind, is there a venous sinus thrombosis? First of all, go for all your sequences. Look at the T1, particularly if there is some high signal in the sinus or not. And then go for anatomy. Anatomy really is the key here. So compare the jugular foramen on the right side and the left side in this case. It is the CT scan of the same case. Uh, so this case. And you will see that the jugular foramen on right side is much larger as compared to the left. Look at the sigmoid notch. This is the sigmoid notch. Here the sigmoid notch is not even visible. So the point is that this is a normal variant. So this embryology tells us that this is a normal variant. Now, coming back to your case. So in this case, uh, just a bit of fine touch, though your diagnosis was correct. Now, first of all, this is intraparenchymal hemorrhage in a 32-year-old. This hemorrhage is going all the way till the cortex. When the hemorrhage is going till the cortex, this is not a vascular territory. In a young patient, think neural, sinus thrombosis or cortical vein thrombosis. Of course, cavernomas or any associated vascular malformations will be in the differential. Now, so this, and then we went to the T1, sorry, this thing, MR. And an MR, key finding was, so I have not shown you this, but what happened was that this was the missing sinus, and that is why it was called as possible venous sinus thrombosis. But by the way, anatomy also tells you that the hemorrhage is up there, And if there will be hemorrhage, it might be because of a cortical vein, but not because of the venous sinus. The transverse sinus doesn't correlate with that anatomy. So all of these concepts are important for you to remember. Now, the key finding here was this T2 weighted sequence where you picked it up very well, but there was just a bit of fine touch. If you see here, there is hemosiderin rim and there are multiple locules. With that, there is associated hemorrhage. So there is a hemorrhage secondary to the cavernoma, and I showed you this T1 also for that. In this case, we have done a post contrast also. This is a post contrast, and this was done just to, for academic reasons, just to see any DVA. There was nothing, no DVA. And by the way, you can see this hypoplastic transverse sinus even on this post contrast. Okay, well done. Thank you.
Thank you.
Adam, I think this is another case for you. Yeah, over to you.
Yeah. Okay, so this is frontal projection of a fluoroscopic study. It is barium enema.
Is it?
No, no, not barium enema. It is. We can see opacification of the colon and it's not the rectum, so it's upper GI contrast study.
So what is this where I'm pointing out?
Is it the fundus of the stomach?
Is it? This is the SI joint. SI joint.
No, yeah. So this is the descending colon.
Then what is this? And it goes into this and then continues here. Okay, let me give you a hint. The patient is prone.
Okay, prone. I don't know.
Okay, good. Okay, madam, I will take over. This potpourri is, I am showing you barium. And I know that the current generation, you don't see bariums. Please remember, still they come in the exam. And, or should I say, they can come in the exam. Same pathology, if I had shown you on a CT scan or an MR, you would have picked it up. Here because your eyes have never seen it. So let me go through it and then we will come back to this case. Now, and I intentionally showed you a prone, and this happens in the exam. Classically, it happens. So examiners are trying to see if you know how a barium follow-through films at times are taken prone, and then the ileocecal junction will appear on the other side. That is the catch here. Now, this is Crohn's disease on barium meal follow-through. So I will go through a bit of Crohn's disease, on follow-through examination. Will you get it? I have no idea, but in the past these films were very critical. Having said that, they can still ask you if can you go into the exam without knowing it. No, you cannot, because they still at times ask. Now, this is an MR study. This MR is a T2 weighted sequence. This is post contrast sequence. We can see that this is the terminal ileum. Going to the ileocecal junction, you can see a bit of distortion of the cecum. It is thick walled. There is, what we call, this is the mesenteric border, and you can see what we call the comb sign, prominent vessels there. More proximally, there are other loops which are involved, though I have just shown you a static image, and these are adherent to this loop. So these are ileo-ileal fistulae. So
Hmm.
they are communicating with each other. Now, on a barium examination, now this is other way around. Now here, what has happened is that this is a barium meal follow-through examination. Classically, what happens is that once you reach the ileocecal junction, you use a compression device. This is a compression device. This patient has not been done in a prone. So for your, the cecum is here. In your patient, the patient was done prone, so the cecum was other way around, and this becomes at times very confusing. Now,
Hmm.
this is the terminal ileum. Now, before that, there is a loop here, and if you see, there are ephthoid ulcers here. There is a crater and surrounding edema. And uh, then this is the stricture. This border is known as the mesenteric border, and this one is the
Anti.
anti-mesenteric border. Now, the on the anti-mesenteric border, in a chronic case of Crohn's disease, there will be pseudo seculations. If you see, there are seculations here, and there are none here. I'll show you quickly a few cases just to develop your eyes.
Yeah.
So one differential which you have to remember is ephthoid ulcers. This is how it looks like on a endoscopy. Uh, and the top differential for ephthoid ulcer anywhere in colon or small bowel or stomach or esophagus is Crohn's disease. It's a deep ulcer. Of course, there is other differential, and this is not given in your present Chapman. This is from sixth Chapman. Now, uh, ileocecal junction per se can also be involved in TB and the cecum, and there are various discriminators, but at times it all depends where you are. So, for example, in UK, every patient is Crohn's disease, but if you are working in the subcontinent, maybe every patient will be TB, and there is more involvement of the cecum in TB. So coming back from this was a Gurkha. So this is TB. Uh, Here, if you can concentrate on this film, this is barium enterocolysis study, in which what happens is this is the anti-mesenteric border. So look at this concept, which I'm now going to tell you. There is a linear ulcer. This is a linear ulcer, right? And the mucosal folds are sort of radiating towards it. Because of this radiation, what happens is that there are pseudoseculations on the anti-mesenteric border. Now, take this concept further. This was a classical, exam film, this one which I am showing you. This is known as cobblestone appearance. Now, what happens in cobblestone appearance that there are thick linear ulcers. These are ulcers, and the mucosa in between is not all that involved. So it gives you a filling defect, and this gives you a cobblestone appearance. Another point is that when you see them and face, this is it. You can see it is projecting into the wall. Look here how it is projecting. So these are deep ulcers. These are deep ulcers. And this they will ask you, they will show you deep ulcer, rose thorn ulcers, for example, like this, rose thorn. So develop your eyes to look for rose thorn ulcers in a profile and this cobblestone appearance. Now, this is a chronic barium follow-through examination in which what is happening is that this is the terminal ileum, close to, not exactly the terminal ileum, just proximal to that. So this is the terminal ileum where I am pointing out. So there is a stricture there. There is a connection between this. So ileocecal fistula. Another fistula from here till here, ileocecal fistula. But if you look carefully on this film, there is contrast in the bladder, and this is the type of thing which they will show you in the exam. If you look very carefully, you can see a thin, discontinuous looking track going here. So there has to be a enterovesical fistula. Even if you don't see this track, you will still call it a fistula because contrast should not have been in the blood. So this is a more chronic case. Look at this here. When you get a contrast examination in the exam, first of all, try to orient yourself what has happened. Here, this is a barium enema examination. You can see contrast here in sufflation of the rectum and the sigmoid. With that, what has happened? And you can see the cecum here. What has happened? That there is a fistulous communication, rather two fistulous communication with this small bowel loop of the ileum. So there is, entero colic fistula here, or rather two fistulae there. So this is another one. Another chronic type of appearance where what is happening? This is the rectum. This is a barium meal follow through examination. So remember, this is not a enema examination. This was an enema examination, right? And this is a barium meal follow through examination where all of these loops are filled up. And you can see this stricture of the ileum, and you can see these maybe two odd fistulae, and then you can see this fistula also. This one is with the sigmoid. All of these things, most commonly in the exam you will get a CT scan on where all of these things are visible, and I think I have shown you quite a few cases in the past. This is a classical example when the contrast is at the wrong location. Contrast at the wrong location is a very important exam fill. Basically, you cannot infer anything happening as far as the small bowel. But why is the contrast in the bladder? That gives you there has to be an enterovesical fistula. So these are the types of films which should be, which at least you should cover for your exam, even if less likely that in this era you are going to get it. Now, if you look carefully, basically confusion was that this is a prone film, so the cecum is sitting here, and then there is that long segment stricture. Now, if you look carefully, look here, the rose thorn. You see this thing? This rose thorn is a finding. When you see a rose thorn, it's a deep ulcer. Means there is another rose thorn here. So that also goes in favor of, because in large bowel, I'll show you cases maybe in future where how do you differentiate between ulcerative colitis versus Crohn's disease on a barium. So these rose thorn ulcers are very important, which you will not see in UC. UC doesn't go deep. The ulcers are not deep. Okay, madam. Thank you very much. Well done.
Thank you.
Candidate 2, are you with us? Let me, I think candidate 2 is not a co-host. Let me make co-host. Candidate 2, are you with us?
Yes, Sam.
Madam, just 1 second. Over to you. So this patient was orthopods. What is the age? Let me see. The age was 42 female. They were worried about FAI, as in femoroacetabular impingement. So they had done, this film for hip joints. And there is a bit of findings in relation to the hip joint. I'm not interested. Uh, uh, so, but what else is there on the film? Over to you.
Okay, this is a frontal radiograph of the pelvis. There is abnormality involving the left iliac wing with areas of multilocular lucencies mixed with areas of sclerosis, which are mostly marginal. There is no associated soft tissue mass or periosteal reaction. Um, it has the zone of transition is fairly it's indeterminate. I'm unable to appreciate any other similar lesions. So, in summary, this is a solitary mixed lytic uh, and sclerotic lesions with evidence of calcific density. Uh, so, in this 40-year-old patient who is asymptomatic, I'm suspicious of a chondroid origin lesion involving the left iliac wing. I would like to see any other available previous images and orthogonal views if available.
So they did an MR actually, and because of time factor, I'm going to go through it. This is a T2 weighted sequence. Uh, so this is the appearance on T2 weighted sequence. Now we have got a T1, and this is the appearance on T1 weighted sequence. And then we have got, I think, a fat set T1, which is uh, doesn't add anything for you. We have got a stir sequence, which is this one. And let me go back to the T1 non-fat set. Here you are. So if you want to scroll through it, but should maybe I can scroll because it's nothing complex. You can see the lesion. So what do you think is happening?
So there is the previously described lesion appears to be within the left iliac wing. It is causing mild expansion of the bone with sclerosis of the cortex. I do not see any associated soft tissue mass or periosteal threading. However, anteriorly the cortex is slightly thinned and merging with the iliacus muscle. The signal intensity is very bright in T2 and low in T1. I think it's too bright to be chondroid matrix. So this appears to be a cystic lesion. I do not see any blood fluid levels. I'm suspicious of a cystic lesion within the iliac wing. My differentials could include the bone cyst. ABC is less likely in this position, although, and also they do not have uh, blood fluid levels. Other differentials, it appears to be a less aggressive lesion. I could also think of fibrous dysplasia with cystic change. My differentials,
Hey,
I would
madam,
like to.
thank you. Thank you. We'll come back to you.
Yeah.
Now, my PowerPoint is hanging. Yeah. So this is fibrous dysplasia. So we'll come back. I'll give you a feedback about whatever you told. Your diagnosis was correct, but a bit of feedback I'll give you. Fibrous dysplasia. So fibrous dysplasia classically uh, is ground, definition, ground glass appearance. But please remember, it is not just ground glass appearance. Uh, so the definition of ground glass is glass whose surface has been ground to produce a flat but rough matte finish. So this is ground glass. Right? If you go back to your pathology and you can make your radiology from there. Basically, in fibrous dysplasia, the dysplasia is in the medullary cavity, right, of the bone. Now, there is fibrosis of the medullary cavity, one, and with that, there are cysts in the medullary cavity. These cysts can be serous or they can have blood in it. Now, with passage of time, the fibrous tissue uh, shows as develops ossification, and it all depends at which stage you pick it up, because the it might be classical ground glass. So if you see this example of polyostotic fibrous dysplasia, look at this metatarsal, And the phalange, this is classical loss of gray white matter differentiation, not gray white matter, cortex and medulla differentiation, and then this lucency in the distal phalanx, which has got more lytic type of appearance. And with that, you can have these kinds of ossification, right? Because it all depends. uh, there is a spectrum, and of course polyostotic is very important for the exam. That is not my aim in this case. This case is a unilateral. You did very well where you ruled out any multiple lesions. But if you look carefully, this case presents with fracture, and with that fracture you can see surrounding sclerosis, and this is what this case was about. So this is the case. Once again, you can see this pathological fracture, young patient, classical exam film, this one. And with that there is a fracture. You can see a bit of ground glass, and you can see this surrounding sclerosis. Now on CT scan, this is much better seen. If you look inside, you can see, a bit of cystic change, and you can see the fracture here. Now, this is what we call rind of orange. So there will be thick sclerosis. It is considered quite pathognomic for fibrous dysplasia. Thick. And this is that fibrous tissue at the periphery which has shown ossification, means it is sclerotic to our eyes. Rind of orange. Now, this is another example of rind of orange. Now, this is very similar to the case which I showed you. Very, very similar. Similar, this. Now you can stretch your imagination about rind of orange. Here it is a polyostotic, and there are changes here and there are changes here. And uh, and if we go to a CT scan, you can see uh, this that lucency there, and there is another lesion here, and another maybe here. So this was polyostotic fibrous dysplasia. Now coming back to your case, please remember that plain film is at times more, but for what we call specificity of a lesion, a plain film is still very, very good, and at times better than MR for specificity. And that is why MSK radiologists, they always correlate plain films and then with the MR. Here, uh, this is the appearance, that rind of orange. It was asymptomatic, but MR really increased our level of confidence. Uh, One take home point is that there is no pathognomic finding of fibrous dysplasia on MR. Please remember this, because it can vary. There can be fluid levels and things like that. But you did very well when you described it. It was a sort of a benign looking lesion with high signal here, and just like CSF, fibrous tissue can appear high signal like this. And then if you look carefully, look at this T1 mutant sequence, and you can see, this margin. And did you see that this margin was higher signal than this? So there is ossification there. That is why it is giving you this appearance. And there is no lobulation, no internal lesion, no cortical destruction, etc. It's very benign. So this is all fibrous dysplasia. As far as one thing is that you mentioned simple bone cyst in your differential. Madam, should you have used simple bone cyst in your differential?
No, should, it in the
Age, age,
age, yeah,
age, age,
yeah.
age. Please remember, in the exam, the key thing is the examiners want you to tell the differential in this patient. And this patient was 40 something year old, right? Simple bone cyst doesn't occur. in this age group. Simple as that. And of course, radiologically also, it was different. So that will not give you that type of margin. Okay, well done. Okay, now this is a 20-year-old presents with bilateral foot pain. So they did X-rays. I will show you only the lateral view of both foot. Over to you. This is the left.
I'm being provided with a lateral weight-bearing wave of the foot. Of this patient who is presenting with pain. I, uh, I think there is elongation of anterior process of the calcaneus. Uh, I'm suspecting an eater sign. I would
You are worried
like,
about.
yeah.
Okay. So I will show you. So what are you worried about?
Calcaneo-navicular coalition.
So what will you? Which view will show you that?
He dorsopalmar weave.
Dorsopalmar. You're using hand terminology. What are
Yeah,
what,
PA.
PA? So AP film of the AP or oblique. This is an AP film. This is an oblique film.
Yeah,
So
oblique film.
yeah.
Yeah.
So this is your navicular. This is your calcaneum.
Yeah, so
Let's go
there's
back.
there's no
Are you
evidence
convinced?
of, yeah,
No, no evidence.
no evidence.
Do you see this thing? What is happening here?
There is light tailor beak is projecting above the
Should there be a
navicular.
tender beak in a 20-year-old?
Should not be.
Right. So let's go to the other side.
It is also seen in the right foot lateral wave.
What should
So
we be worried about? Anything else on this film?
yeah, there is a C-shaped appearance continuing the talus with the calcaneum. So I'm worried if this is calcaneo-tailor coalition, which would be better seen.
Calcaneal coalition. What will you do then? Which view would you like to see?
Oblique view.
So I had shown you the oblique view, and this is the oblique view once again.
Okay.
Any other view?
I'm unable. Yeah, the PA
You are
view.
unable. Okay,
APV.
Okay, if you want to do another modality, which modality would you like to do? Yes.
I think CT scan of the foot, the metatarsal.
Yes. Okay, we have done an MR. Over to you.
Okay.
I'm showing you just one side, and I'm not going to show you the other side because of time factor. Give me the diagnosis here. Over to you.
Can I scroll?
Yeah, you can take the mouse, mouse for the mouse.
I have requested.
Yeah, here you are.
Okay. So these are MRI corner sections of the foot. So there is abnormal, there is reduced space with abnormal junction between the calcaneum medial process and the talus with evidence of bone marrow edema of the medial process of the talus. The synchondrosis between the two joints. There is evidence of cartilaginous interface between the two bones. So these findings are in keeping with cartilaginous synchondrosis between the talus and the calcaneum. I would also like to see the contralateral foot MRI and would like to, this is causing bone marrow edema. So the patient is symptomatic, should be referred to the orthopedic team for further management.
So what exactly is this joint? Which joint is it?
It is posterior talocalcaneal joint.
How many joints are there? How many facets are there?
3 facets are there.
Name them.
Anterior talocalcaneal, the posterior talocalcaneal, this one I'm not sure.
Okay, madam. Thank you. So you were right. This is subtalar coalition, also known as talocalcaneal coalition. So first of all, a bit of concepts, and from there, how it will, how the examiners are going to show you in the exam. It will start always with a plain film. Remember this. A bit of anatomy. Now, this is the calcaneum, and there are 3 facets here: the joint between the talus and the calcaneum, the anterior, and this is the middle articular facet, and this is the posterior. The posterior is the largest, but this middle is projecting medially. This is the sustentaculum tali, which projects medially. And most common involvement is of this one in coalition. Of course, others can also involve, but the most common is this. So this part of anatomy you should know. Now, coming back, there are various kinds of foot coalitions, and uh, does not mean that only these two can happen. There are more than that, but the most common are calcaneo-navicular and the talocalcaneal. Now, please remember that up to 50% of them are bilateral. So the VIVA tape, a classical questions the examiner are going to ask is, what are you going to do next? Because of time factor, I just tackled it a bit differently. I just showed you both myself, but classically in the exam, they will ask you, what will you do? I will, even if it is asymptomatic, but you did very well because you knew that. Now, you also did very well in describing this concept. Coalition can be bony, it can be fibrous, and it can be cartilaginous. Now, this is a, so the case will be presented to you on a lateral. On a lateral, other than some other signs, the first thing you have to see if there is talar peaking. The dynamics of the joints are all abnormal, and that is why you will see osteophytes here. And this is what is known as talar peaking. This is a 9-year-old female. Now, the key point to remember is that as far as plain fin is concerned, the navicular
Excuse me, Dr. Khan, we are not able to see. Now we can see.
Yeah. Sorry, you were not able to? Now you can see.
Yeah, the arrow we were not able to see earlier. Now we can see.
Right. So the key point to remember is which view are you going to ask you? You are going to ask for. For calcaneonavicular collation, you have to ask for an oblique view of the foot. In this particular case, if you look carefully, you can see this irregularity. Some space is reduced here, and this must be a cartilaginous or a fibrous type of collation, and there is a bit of sclerosis irregularity. On the other hand, the subtalar or the talocalcaneal naviculation axial view. Axial view is very rarely done. This is one of the indications. Of course, axial view is also done to pick up calcaneal fractures. And it comes in your rapid reporting also, axial view. So this is a close-up of the same, and you can see is on an oblique. So I repeat, for calcaneonavicular, ask for oblique films, for oblique views, and for talocalcaneal, ask for axial view. And this is a classical exam question. So this was calcaneonavicular collation. Now, this is another example, 13-year-old painful rigid left flat foot. And so look at this talar beaking here. And this is an axial view. This is what they will show you in the exam. And you have to develop your anatomy. Remember sustentaculum tali, which is projecting medially. Superior to that is the middle facet. Remember this. This is the middle joint. Look here, and it is normal. Look here, and it is reduced. It is irregular. There is a bit of sclerosis. So of course there will be patients in which whole of this will be completely ankylosed. Bony ankylosis will be there. So this anatomy is critical for you to remember. And this is a 21-year-old where you can see this talar beaking, and you can also see this C sign. This is known as C sign. And on a CT scan, you can now there is a bony collation and at the same joint, at the medial joint. And this is an MR of the same patient. And you can see bone marrow going from this to this same bone marrow. So there's nothing new, but just to highlight that on a MR, how will it look like? This patient is for anatomy. This is a CT scan. And the posterior facet, this is the posterior facet, which is the largest facet. Fibula is visible, right? And in this case, look, this is normal, and this side is abnormal. This side is abnormal. And then more anteriorly, the abnormal. Now here, this is the middle, and this is abnormal and normal, abnormal and normal, and then comes the anterior. So these were a few examples. Now you did very well, and except for the view, I think the views which you asked was the only thing which needed to be corrected there. So you got this, and with this you should ask for either axial. By the way, I did not have an axial. You did ask for a CT scan, which is fine. It was my choice to show you an MR, where you again picked it up. And on CT scan also, this is a CT scan. I'm not showing you the bilateral views just to highlight the same part of anatomy. And you can see that there is no, complete bony collation, but there is a bit of sclerosis, irregularity, and bilateral. So a bit of cartilaginous type of collation is there. Well done. Okay, then, so madam, do you do barium enemas in your clinical practice?
Yeah, I have done.
You have done, okay. So favorite, huh? Yes, favorite or not favorite?
Not favorite.
Okay. Over to you. Over to 65-year-old female.
Okay. These are spot views from a barium enema study, like a double contrast barium enema study. I think it's an oblique wave. The sigmoid colon appears to be projected in face. There are multiple diverticuli in the sigmoid colon. in the center of the sigmoid colon, I see a abnormal filling defect with evidence of apple core appearance and a narrow
Where
string.
here? Are you talking about this thing?
Yes, center here.
Let me show you. Can you reconsider that apple core you were talking about? Is there an apple core?
There's a stricture in the central part.
This part.
Yeah.
Okay. Okay. Please continue. What else is happening?
There is apart from that, the rectum appears distended well, and I noticed a separate loop of bowel projected loop of possibly bowel projected to the posterior and to the right side of the rectum.
This thing? This thing?
Yes. Yeah, I would like to see another view if possible.
Okay, so you are right. So what do you think is happening?
I'm suspecting abnormal communication
With
the vagina.
right. So what is your diagnosis?
In that case, it is a colovaginal fistula, probably secondary to diverticular disease or previous surgical or malignancy in the uh, cervico-vaginal region. So I would like to suggest cross-sectional imaging and evaluation of the patient's history for further
Okay, so
characterization.
I was about to stop you. I said very well done, and then you went into so you got a diagnosis which was uh, colovaginal fistula secondary to diverticular disease, and this is what it is. And then you confused yourself, post surgery, post this. So you should have been confident there. Just stop there. I was about to stop you, and was complimenting that you have done very well. In any case, this is a complex diverticular disease with a colovaginal fistula, which can happen. Now, diverticular disease is a very important thing for the exam. Why? Because in UK it is a very prevalent disease, and the rate is extremely high, and you will see every kinds of presentations. You will mostly see it on CT scan. But having said that, the same thing can be on other modalities also. So, complex diverticulitis with vaginal fistula. Now, let me give you a few concepts. Now, if you go into histology, so what happens in diverticulosis? This word should be in your vocabulary. Diverticulosis means diverticular disease. And when there is inflammation with it, then we call it diverticulitis. So this is a CT scan where you can see that there is a fat standing here, a bit of gas bubble, and this is diverticulitis. Now, but what we are concentrating here is on the stricture. Now, stricture, if you go back to your histology of a diverticular stricture, you remember there are layers of bowel, mucosa, submucosa, muscularis, and then the serosa. So there is muscular hypertrophy. This is a very unique stricture. The muscles they become hypertrophied. So a classical diverticular stricture can give you a sort of a serrated outline, and this is a serrated knife. So this is the type of outline you will get with it, and so if you look carefully, you can see that you know the mucosa, it goes up and down, 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 and this thickening is because of the muscularis. So this is a serrated outline here. If you see on this MR, you can see it beautifully, where you can see this serrated outline. Please remember that this is not seen in each and every case, but sometimes it is visible. On a barium, you will see it more often because barium causes distension. Now, this is classical serrated outline where you can see this, up and down. Just remember this up and down, up and down, up and down, up and down. There is no destruction. So this is a classical. Now, look here. This is a diverticular stricture, and this one is a malignant stricture, and you don't see it. In real world, don't go home with this idea that all diverticular stricture will look like this, but at times, when it looks like this, you are very confident that there is no malignancy. Sometimes in diverticular disease, this stricture is so tight that they will send the patient back to you that we could not do a colonoscopy. It was not safe to pass through it. So let's do an MR, see what is happening. And if you get this kind of picture, you are quite happy. This is another case, similar case to which I showed you. You did well where you asked for more films. You need a classical lateral. In this case, also there are diverticuli, and this up and down mucosa is seen. There is a vaginal fistula. So yeah, 2 plus 2 makes 4. So, and your case was you did very well, and your case was similar. And I just wanted to confine yourself to a single fin. Now, if you see this mucosa, it is up and down. Now, I do get your point where you say that I'm worried about this. Okay, fine, I will take it. I will. But I just want you to develop your eyes. This is all normal. This is all normal. This is up and down, right? Here we are not sure. So nobody is stopping you that say that here I am. I cannot rule out anything. I will advise a colonoscopy. So otherwise, when you see this up and down appearance, this is a diverticular stricture. Well done. Now, your next case. Yes, please. Plain X-ray.
It is a frontal.
Just 1 second, please. This patient is 42-year-old female. She has got a lot of joint pains. She has got dysphagia, finger pains. She also has got some neck pain. And initially, they did a X-ray of the cervical spine. Over to you.
Uh, so this is a frontal radiograph of the cervical spine of a patient who has presented with neck pain and other joint pains. I noticed an abnormal foci of calcification in relation to the right side of the neck, which is overlying the right side of the uh, upper cervical spine pedicles. Apart from that, the
Right. So I've got a lateral view. Does it add to anything?
This the abnormal calcific density is projected posteriorly, probably in the uh, posterior cervical musculature.
Okay, just 1 second. CT scan. You can scroll through it. You can ask for the mouse. Or should I? Okay, let me show you. So over to you. Just concentrate on this calcification or ossification, whatever it is.
So there is evidence of globular calcific density in relation to the upper cervical vertebral body, right side. I think just trying to see the relationship with the facet joint. Uh, it's, it's mainly periarticular uh, and appears to there's cross profuse calcification lobulated and also displacing the cervical musculature, and I see extension of the calcific densities towards the transverse foramina of the relevant vertebra causing narrowing. I'm concerned if there is any compression of the vertebral artery on the right side. I would also like to see the coronal images or sagittal images further.
Right. So that's fine. That's fine.
Okay.
Because of time factor, what is happening? What do you think is the cause of this?
So this is basically soft tissue calcification with the patient presenting with multiple joint pains. This could represent systemic pathology such as sarcoidosis or calcemia. I would also like to see these patients other joint X-rays if available. This is less likely to be synovial osteochondromatosis because it does not show any relationship to the facet joint. So my primary diagnosis is soft tissue calcification either due to sarcoidosis or hyperparathyroidism.
Okay, thank you. Right. So, this is a case of scleroderma.
Okay.
Now, the main thing, this is a differential diagnosis case, and you have to refer back to your Chapman and, you know, have got very clear cut concepts. Each line at times saves the case for you. And soft tissue calcification and, common causes, less common causes, the concept of dystrophic calcification in abnormal tissue in the presence of normal calcium metabolism. Less common, metastatic calcification, which is calcification in normal tissue in presence of abnormal metabolism. So this is where you talked about hyperparathyroidism and renal osteodystrophy, etc., can come into this. Now, systemic sclerosis. This is a systemic sclerosis case, right? And there are other things which can cause this. So, was sarcoidosis a good differential, madam?
No, I think I
No.
confused it
Yeah.
with the
So
systemic
this is
sclerosis.
the point. Yeah, this is the point. This is the point. Yeah, one small, here and there, and the case goes down the drain, because this is the radiological finding is easy to pick up, but I'm just trying to see your knowledge on the subject. So scleroderma, of course, is a multi-system. I could not have been more elaborative, so I did not tell you that there is Raynaud's phenomena, for example, but I did tell you that finger pain, joint pain, dysphagia, and with that, all of this, right? So that was also a clue. This is a case of scleroderma with calcification around the knee. Of course, in most of the patients, the calcification is in the hands, in the fingers. This one is, this pseudo circulation in the transverse colon, but look at these calcification, which is right and left in the pelvis. And we know that systemic sclerosis is a multi-system disorder. It will involve all of these. And in GIT, they show a lot of films, they can show CT, MR, they can show bariums, hidebound type of gut. You of course refer back to. But this case was, in a way, I was trying to see your knowledge on the subject of soft tissue calcification. So you did mention systemic causes. Your thinking process was good, but then sarcoidosis, that was a wrong diagnosis, wrong differential, should I say. So this is another case of scleroderma. Another thing which I want to highlight to all of you is the difference between soft tissue calcification, which the candidate did very well because she was conscious of that, versus soft tissue ossification. This is post-traumatic ossification. Look at the trabeculae, etc., and try to never confuse these two things. This differential is quite small: trauma, myositis, post-surgical paralysis, parosteal osteosarcoma, etc. And this is, the definition from Radiopedia. Heterotropic ossification refers to presence of bone in soft tissue where bone normally does not exist, uh, exist, extraskeletal bone. And myositis ossificans, of course, is a very important exam case. That is not my, I don't want to go through the details of it. But having said that, the concept is the same, that myositis ossificans, which is well established, will give you this kind of appearance. Okay, thank you. Now, your next case. Next case is, oh, by the way, as a, look at this. This was on a brain MR. Do you see this? And I could have started from there, and extra neuro findings on a MR of the brain, that kind of a thing. Okay, so here what happens is, this patient, I'm going to, because of time factor, I'm going to describe it myself, and then I'll ask you a leading question. Are you with me, candidate 2?
Yes, I am.
This patient presented with stroke-like symptoms, right-sided stroke. They were worried about left-sided, findings. The patient had a previous chronic stroke. So on this MR, we could see a possible hyperdense MCA sign, and we can see possibly partial insular ribbon sign. And if you go to stroke window, it is more convincing here. So, and maybe portion of the basal ganglia here is also involved. So there is a bit of hyperacute stroke which correlated clinically. Now, so I'm going through the case myself because of the time factor. So suppose you have done all of this, right? So you have said that I am worried about that there is a acute, MCA, and this is chronic, and you have gone up and down. Now, anything else you will like to do or see? Over to you.
Yeah, I would like to ask for a contrast CT angiogram study.
Okay. So before that, anything else you would like to do?
Look at the bone window.
Bone window. Okay, let me give you the bone window. Over to you, madam. You can ask for the mouse.
Yeah, I have asked.
Yeah.
So I'm unable to appreciate any lesions, lytic lesions in this
Look
patient.
at the base of skull.
So in relation, in the clivus, there is evidence of lytic area in the right side, the right of the clivus, which is also abutting the horizontal part of the carotid canal.
I'll change the window back to, I think, UX. Yeah. So you are absolutely fine. Now you have picked up something in this region, right?
So I would like to further evaluate with an MRI scan.
Okay. So I am giving you a T1 weighted sequence. Here you are.
I'm looking at the concerned area in the T1 weighted sequence. It shows evidence of soft tissue intensity lesion to the right side of the clivus. I would also like to evaluate the post contrast and T2 weighted sequence.
So this is not, ideally we should have had a fat saturated post contrast, and we did not have that. So this on this post contrast, this is the appearance. Actually, this is fat saturated section. It does enhance. It does.
Yeah,
now, what is your differential?
So it's in the region of the ketoclival region. My differentials in this region include clival chordoma because it's laterally chondrosarcoma is also another differential, and metastasis is the other differential from this lesion.
Okay, thank you. Well done. You did well. The only thing is a bit of fine touch of the differential, which I will come back to. So the chordoma you were referring to, where does it happen? Chordoma? Is it in the center or in the slightly
center? In the center.
This case was center or?
This is a lateral.
Right. So this was acute infarction left, which this was a satisfaction of search type of patient. Satisfaction of search is when you pick up one finding and there might be another, and of course in every case the examiners will not even allow you to go to the bone window. If they are interested, they will, but it is a good idea for you to ask the examiners that I will like to see a bone window, or in my usual practice I will see a bone window, and if they want to show it, they will show it. So that was a satisfaction of search. So I am going to skip the infarction part of it. Now this is the anatomy. This is the clivus. Please remember, portion of the clivus is made of what we call the sphenoid bone, and this portion is made of the occipital bone. This is the petrous apex, so this is the temporal bone, the petrous part of the temporal bone. There is a synchondrosis here, and of course there are multiple synchondroses sitting here. The key point is that the differential chordoma versus chondrosarcoma, you did say metastasis, which is absolutely fine. Lymphoma, metastasis, myeloma, all these things can happen. But chordoma will be central, chondrosarcoma will be off center because it arises from this same chondrosis. So now this is, excuse me, this is the concept of the synchondrosis, which I have in a baby, in a child, you can see busy sphenoid synchondrosis here. So this also shows you that the clivus has got two parts. This is a case slightly different, similar pathology in which you can see a larger lytic lesion, and you can see on a T1 weighted sequence the marrow is destroyed and clivus is involved. So this is the picture of chondrosarcoma versus chordoma, which will be more central. And in chordomas can occur here at the clivus, or they can occur in the sacrum also. And you will see fluid, as if there is fluid inside, and there will be destroyed bone which is floating in it. On the other hand, in a chondrosarcoma, you can see chondroid matrix. So this is unifocal skull bone lesion, 1235. Chondrosarcoma arises from the skull base, from synchondrosis, petroclavicle, clival, or all of these, and the same things which I have just told you. And the clivus lesions also. Chordoma is the differential, and as I've told you that this arises in the midline near the spheno-occipital synchondrosis. So this case was for differential diagnosis. The concept of chordoma is that it occurs at the two ends of the notochord, so clivus, and on the other hand sacrum. And even here in this example, you can see a peculiar finding where it looks like liquefied, and there are fragments as floating on it. So, candidate 2, actually, I gave you an extra case if I'm not wrong. Yes. So, thank you very much, candidate 2. We have got 3 cases left, and we have got about 30 minutes. That's fine. Candidate 3, are you with us?
Yes, sir.
Okay. Just 1 second, please. This is a 28-year-old presented to A&E with vague history. He is slightly disoriented, brought by some passers-by. So he is okay, but he's a bit disoriented. Over to you.
I am provided with frontal radiograph of this culturally mature adult chest, and I see some retrocardiac opacity on the right side. Other than that, I do not.
Just 1 second, please. Just one. If you are worried here or here or here, don't worry about it. Over to you, please.
Okay. Okay, I see. Chest looks clear to me. There is no pneumothorax, and I'm checking the skeleton. The bones looks at normal as well. I'm not sure if there is a dislocation on the left side. I think it's dislocated left shoulder joint. There is incongruity in the glenohumeral alignment. On the right side, it's not that clear, maybe because of the window, but it looks okay. So based on this chest radiograph, I suspect that there is a left shoulder dislocation.
Okay, well done. Thank you. So, this is a case of warm-up film in the exam. Actually, there were bilateral shoulder dislocation. I'll come back to the film itself. You did very well, uh, where you picked up one, but there was on the right side also. These kinds of films are for observation, and once you pick up the finding, they will go to the next film. These observation films are at times shown. Some of the examiners will show you as the first case in the VIVA. They are easy, but it is for observation. It is very critical. You did well, where you sort of went through your protocol, and in the exam films, at times, even it might be more subtle finding than this. You loser zone of osteomalacia, for example, on a rib. For example, rib notching, things like that. This is another example where we can see, if you see, this is supraclavicular fat, and look here, that fat pad is gone. So this was a case of a soft tissue sarcoma arising here and invading this part of the bone. But these kinds of x-rays, the key thing is that when you see these kinds of films, never keep quiet. Never keep quiet. Start talking, start describing. And if you are quiet, then what happens is that you will go into a panic mode. There will be so much adrenaline rush that you will go into a panic mode. Second thing is that uh, when you are going through your protocol, it increases your chances of picking up the finding. Simple as that. And third thing is, at times it gives uh, good impression to the examiner. And even if you don't get it, they will give you some credit, because they will say that at least you have got a good viewing protocol, and they will, even if they want to give you marks, they might give you 5.5 instead of 5 or 4.5 on the same film. You remember, 4 is 0 in a way in the exam, and you have to get 6 in each case, well, or in total, I mean to say. So your aim is that even if you drop a film, you should get maybe half a mark, so that you can compensate it more easily. So keep talking is the key thing in the exam. So this impression is important, but another thing which is important is that at times the examiners will then at a particular point help you. And you should have a viewing protocol for each and everything, whatever you report. We historically, we always teach viewing protocol of a chest X-ray, but we don't teach a viewing protocol of a knee X-ray or a shoulder X-ray so you should have whatever, you should have a viewing protocol. So it is important tip for the exam. Now coming back to your case, which is this one. So I think part of the problem might be windowing, but the window, intentionally I had given you this window. If you look carefully, this is the glenoid, and you picked up that this is the head of the humerus. Here, this is the glenoid, and where is the head of the humerus? It is sitting here. Of course, you can ask the examiner that I want to change the window. So now, if I change the window, you can see that this is the glenoid, and look at the head of the humerus, which is so incongruity bilateral. And then, candidate 3, what are the causes of bilateral shoulder dislocation?
Usually, in seizure, we do see bilateral and posterior usually. Posterior can also happen.
Yeah, so this is what happened with this patient, and he was very disoriented. He was not cooperative, and electric shocks can also have the same type of appearance. But you can see that it is visible here also. Okay, well done. So this is from our COVID files. So in COVID, what happened was that because in UK, COVID was horrible, and the first doctor we lost was a ENT surgeon, and then what happened, there was a surge of MRs. So we have done MRs of the neck as a screening tool, absolute screening tool, MR of the neck. So this is that kind of an MR from the COVID era. Over to you. This patient is so what I'm trying to tell you is that the clinical was that the patient has got sore throat, rule out any pathology, that kind of a thing, because they had not done anything as an endoscopy, which they usually do, right? So uh, over to you. 28-year-old neck MR.
It's just this is a axial situated sequence of the brain and neck of the brain. Okay, I see there is a T2 hyperintensity in the right maxillary sinus, also on the left side, um, and okay, other than that,
So other than that, everything is normal. So incidentally, you have picked up something in the maxillary sinus. Now, what is that?
yeah, I see a sorry, I see a hypointense area in between, in the middle region of this abnormal, which could be teeth or calcification, since it is in communication. This happens to be in communication with the mandible bone. I am trying to see if that is a floating tooth.
Would you like to see anything else?
Yeah, I would like to see the coronal, if just
Okay, 1 second, please. Over to you.
I can now scroll. Yeah, so it's filling the entire maxillary antrum, and it has multiple septations, and there is no um, mucocele would be a consideration.
What is your conclusion?
Mm, right maxillary sinus mucocele.
Would you like to do something else?
I would like to see the T1 or the fat, or yeah.
So, uh, what sequence is this?
This is a T1 coronal.
So you asked for
So
T1. So this is a T1.
yeah,
This
so
is a T1 fat set.
okay, so I see hyperintensity in the T1 fat set. So this would be more consistent with proteinaceous fluid, or a hemorrhage. Proteinaceous fluid would be more likely.
would you like to do something to reach a diagnosis? What, you're talking about a mucocele here, right? Is that your final diagnosis?
Yeah, yeah.
Okay, thank you. So let me go back to the PowerPoint. Antigerous cyst. Initially, you were spot on. And please remember, in head and neck, what happens is never be shy of asking for a next modality. In MR, ask for a CT, do a, if the MR doesn't give you answer and you want to see it, even a plain film would have given you the same, would have confirmed it actually. So never be shy of asking for the next modality. And this is what we do in head and neck as a routine. Now, this is bony lesions of mandible and maxilla 12.21 from your book, dentigerous cyst. Developmental cyst associated with crown of an unerupted or impacted tooth. Actually, you picked it up. The only thing is you wanted to confirm it. Even a plain film would have confirmed it, or a CT would have confirmed it. Most in mandible, especially is third molar, variable size. Maxillary cyst, look at this one. Maxillary cyst expand into the maxillary sinus. So this is what you were looking at. So this is a mandibular dentagerous cyst, which is associated or arising from the crown of the tooth. This is how it looks like on a diagram, and this is another example of a mandibular cyst on a CT scan. But this is, of course, in the mandible, and there is a unerupted tooth there. So don't be shy of asking for a CT or a plain film if you have to. Now, let's go back to your case, and this was your case. So please remember that there was a catch. You were looking at a T1 weighted sequence, and it was proteinaceous matter. It happens in head and neck. Don't confuse it with hemorrhage. Initially, you said protein, then you also said hemorrhage. There is no need of going into hemorrhage because any long-standing cyst will have that. So without going into the details of everything, if we go to the CT scan, and you can see here, this is a tooth, right? So the main idea is just to confirm it, and for confirmation, if I show you a sagittal, I'm sure we will see it very well. Once again, here you are. You can see this tooth. So it has gone into the mesh. The thing is that the you should have asked. Otherwise, you did very well. Last case of the day. Last case of the day is similar to another case. You remember that cavernoma case? It is similar to that. This patient is a youngish patient, 42-year-old male, and presents with this acute symptoms, and they were worried about a hemorrhage. I have partly maybe already shown you a bit of hemorrhage. Please scroll through it. Candidate 1, candidate 3 rather. So today I showed you one case of acute hemorrhagic presentation in which the etiology was cavernoma. This is another youngish patient, 42-year-old male, and presents with, over to you.
Yeah, I'm provided with axial non-contrast CT of the head. I see there is a hyperdense area in the left parieto-occipital region. This appears to have in the parenchyma as it no, I suspect that this is in the along the sulci. as well as in with parenchymal extension, and this is most consistent with acute hemorrhage. I would like to see evaluate it with post contrast study.
How will it help you, the post contrast study?
I would like to see if there is any vascular component as
Vascular component, what do you mean vascular component?
like AVM. I would like to rule out AVM and cavernoma. And
are you expecting to pick up a cavernoma on a CT scan with contrast?
mm, cavernoma would be better picked up in MRI. I'm also looking at the sagittal sinuses to see if there is any evidence of thrombus.
What will you like to do next?
We can do MRI with post contrast. Okay, so I am provided with, and this is flares axial sequence. Okay, I can see a hyper intense area in this region, and
okay, I'll show you more sequences, but just
yeah.
give me the mouse. Leave the mouse for me now. So I'll show you. Let me show you quickly that this is the SWI sequence, and what is happening in the SWI?
In the SWI, there is a marked blooming artifact, which would be
Right.
consistent with hemorrhage and blood
Right.
products. Yeah.
Now, so we have got a T1 here, and on T1, because the hemorrhage was very acute, it is not very high signal. It is not a subacute hemorrhage. But then we have got a, I'll go back to the flare. Now, on this flare, this is the hemorrhage. Something else is visible here. What do you think is happening here? Here.
Yeah, I see there is a dural thickening, and yeah, and it's on the both sides. So I would like to see if there is, if that is enhancing or not. To see if
And if it is enhancing, then
that could be dural metastasis or meningitis.
okay. So what is happening here then? You know, this hemorrhage. Why this hemorrhage? Okay, let me
Maybe
show you
cortical thrombosis, cortical venous thrombosis secondary to.
Okay, so this is a T1 weighted sequence, right?
This
And
is a T1, yeah, and I see there is a hyper intensity along the superior sagittal sinus. No, no, it's yeah,
so let me help you. So this is the superior sagittal sinus, right?
yeah.
Now I'm going towards the left side. You see something here. You see something here. You
There
see
is
that?
hyper intensity, so that could be a clot.
Where is this clot?
It is moving, so it could be in the cortical vein. I mean, in the cortical, yeah, one of the cortical veins.
How can you correlate this with the finding on the flare sequence, where you picked up bilateral, you know, the dural thickening?
Um,
Basically, you have picked up cortical vein thrombosis, which has caused this hemorrhage. But there is another finding sitting anteriorly. Me, that could be
infectious as well. I'm not sure.
okay. Well done. I will let me conclude the case. So this was cortical vein thrombosis, but with that, this was associated with intracranial hypotension. And so two different findings in the same case. So just a recap of anatomy. I'm not going to go into the details of dural venous sinus. Dural venous sinus thrombosis, etc. There are unusual presentation is what the examiners are talking about. They will show you plain films in which, the internal cerebral veins are hyperdense and things like that. So this case is slightly different. So let's go back to the concepts of it. Now, this is this is the superior sagittal sinus, transverse sinus, and there is a concept of cortical veins. Now, this cortical vein, the superior one, vein of Proulard, superior anastomotic vein, and this vein of Lebbe, inferior anastomotic vein. Please remember there is too much variation, so don't think that in each and every patient it will look like this. This is, right vein of Proulard. This is the left one. But if these veins uh, are thrombosed, they are small, right? But they will cause a venous infarction. And venous infarction is hemorrhagic. The surface or the cortex will always be involved. So whenever what we have learned today, because I showed you a cavernoma case, now we are looking at a cortical vein thrombosis. Of course, there will be cases in which it will be sitting next to the sagittal sinus, and that will be sagittal sinus thrombosis. Now, key point to remember is that the cortical veins, it's very difficult to image them, and MR is the key. Because on a CT venogram, they are so small, even if they are thrombosed, because you don't know they should be sitting there because it's not a set anatomy, you will miss it. You won't see it. So on MR, try to look for them on each and every sequence. I've got very good cases. Maybe next time I'll show you one in which we picked it up on a flare sequence. And because the thrombus was sitting inside, like a hyperdense vessel sign type of a thing. Now, but key point is that whenever you look for, in a young patient, when you have got intraparenchymal bleed, particularly extending to the cortex, cortical vein thrombosis or dural sinus thrombosis should be top differentials, particularly in females. Now, another point here is that uh, this is intracranial hypotension, spontaneous intracranial hypotension, and our patient also had spontaneous intracranial hypotension. If you read it in detail today, you will see that intracranial hypotension is associated with cortical vein thrombosis or dural sinus thrombosis. So there is a percentage of patients which will have both. So that was the cause. So in spontaneous intracranial hypotension, if the examiner wants to show you, they will show you a flare sequence. On a flare sequence, develop your eyes that this is the skull, this is the the diploic space, this is the outer table, this is the inner table, and something is thickened. It is a bilateral symmetrical finding. Then ask for contrast, and it will enhance. And this is how this is another example which shows that complete enhancement. And with that, the Monro-Kelly hypothesis, what is the pathophysiology of intracranial hypotension? I have covered it many a times. Let me repeat it quickly. Basically, skull is a closed cavity. And whenever there is what we call uh, if there are three things in the skull cavity. One is blood. Blood is within the vessels. Then it's CSF, and the third thing is water. Water is within the parenchyma of the brain. If something decreases, another thing has to increase to compensate for it. In spontaneous intracranial hypotension, what happens is that because of unknown reason, there is CSF leak. At times, the reason is no, for example, an LP or surgery or whatever. And uh, compensation is by the veins. The veins are sitting in the dura. They have got less compliance. They can dilate. That dilated veins will give you an appearance of dural thickening. And when you will give contrast, they will enhance. Similar concept is asked in head injury, where what happens is that because of edema in the parenchyma, the vessels are compressed, and that is why ischemia develops. So these are two different, presentations which can be asked in the exam, and this, hypothesis must be known. They ask, this is a very usual question in the exam in post-trauma cases and things like that. So in your book, there is meningeal enhancement, dural enhancement, pachymeninges with dura and arachnoid, and it will have intracranial hypotension as one of the causes. So this case is with contrast, and you can see a lot of enhancement. Other signs like sagging of the midbrain, etc., will also be seen. Now, let's go back to the case, which is this one. So here, if you go back here on the CT scan, the key point is that this was a hemorrhage which was extending to the cortex. So always think, dural sinus thrombosis. Now on this flare, which was this one, we picked up this. I am not showing you the post contrast, which showed enhancement, of course. So this was that spontaneous intracranial hypotension. This thing, the only sequence we did CTV, we did MRV, we could not pick up anything convincing except for on this T1 weighted sequence, where I was showing you that the cortical vein, you see, this was high intensity, the clot sitting there. You see this thing? And this is that hemorrhage. This is that hemorrhage. And this is the cortical vein goes, and ultimately it goes into the sinus. It is clotted here also. But sinus itself was not involved, not at this stage. So this is cortical vein thrombosis. Well done, candidate 3. So that is about it. If there is any question, you can, candidate 3, you have any question?
No, sir. Thank you. It was good.
Okay, well done, well done. So if there is any question, quickly, if you can ask me, and I think next week again, I will have a similar session, potpourri session next week. Thank you. Let me know if you find this format useful, because there is a bit of teaching there, and it might be quite intensive, but I feel that it goes to VIVA and then the basic A to Z type of teaching, right? So many of you are interested in these kinds of sessions. Okay. So next session, in any case, I am going to do a potpourri next week, and then we will see. Yeah, somebody has given a beautiful comment, exposes a lot to work on. That's a very good feedback, that this is what it is, the reflection is very important. That this thing I could not understand and go back and during the week just master everything. So this is what it is about. So your own deficiencies, etc., work on that. So if there are no questions, there were many comments. Thank you for the comments. But if there are no questions, then I will beg leave. I'll keep uh, it open for a few minutes and then see you next Thursday. Okay, then. Goodbye.
The recording has stopped.